Hello, welcome to another episode of CLS Live, a live stream series presented by the publishers of Contact Lens Spectrum. I am your host, Jason Jedlicka. It's a pleasure to have you join me today. Each program, I do have the chance to chat with a leader in the world of contact lenses, finding out what's going on in the contact lens industry from their perspective and with their insights. We talk about new and future products, the latest research, worldwide trends in prescribing, and even bring you updates from the floor of contact lens conferences. So for today, we have a focus on one of the hottest topics in eye care, and that is myopia management. And who better to talk myopia than my guest for today's show, Mark Bullimore. Mark is an internationally renowned scientist, speaker, and educator, and he's based currently in Boulder, Colorado. He received his optometry degree and PhD in vision science from Aston University in Birmingham, England. Spent most of his career at the Ohio State University and University of California at Berkeley. Is now an adjunct professor at the University of Houston. He is an associate editor of Ophthalmic and Physiological Optics, the former editor of Optometry and Vision Science. His expertise in myopia, contact lenses, low vision, presbyopia, you name it, means that he's a consultant for a number of ophthalmic, surgical, and pharmaceutical companies. This work has resulted in approval of, among others, Paragon CRT, Alcon's iLux, and Cooper Vision's MySight lens. He has co-authored over 100 peer-reviewed scientific articles, including several modern classics in the field of myopia control. So with that brief introduction, Mark, welcome. Thank you for taking the time to be here today.
Thanks for the invitation, Jason. It's nice to see you. I'm glad to see that you're safe and sound.
As well with you. Like most of our guests on the show, you have about 1 million irons in the fire, it seems, one of which are your ebooks, which are great resources, and your ebook on GP lenses has been a required text for my contact lens course here at IU for the last couple of years. Definitely a great resource. On a side note, how's the weather up there in Colorado? I hear you finally got some snow and maybe got out on the slopes recently.
Yes, I'm actually at Breckenridge this week, so I got a couple of hours of skiing yesterday. Snow's a little scarce, but the coverage is good on the runs they have open, and it was in the low 40s yesterday and sunny, so what's not to like?
Beautiful. Yeah, I'm sure all the ski fans are happy about that. So we've got our coffees today. It's earlier out there where you are, so I appreciate your getting up with me. So before we dive into talking myopia, I briefly introduced you. To do so fully would take the whole show, but let's talk a little bit about the path that led you to where you are now with regards to myopia. Was it something you worked with? We mentioned, Paragon CRT and the MySight. Was it a product? Was it a person in your life that you worked under at one time that was very interested in myopia? How did myopia become one of the big emphasis of your work?
So it actually began in the mid-'80s when I started my PhD, and I really wanted to study visual assessment and psychophysics, but there wasn't really an opportunity to do that. So I ended up working with Bernard Gilmartin on accommodation, and we kind of got more and more interested in myopia because it was becoming a hot topic. So I published a number of papers at that time related to accommodation and myopia. Specifically really interested in late onset or adult onset myopia. Now, a lot of what we published there has since been, I wouldn't say discredited, but updated with other theories and evidence. But then when I was at Berkeley, I got interested again in adult progression, and there was an opportunity to mine some data. So I wrote a grant and got funded by the NIH. And then after I'd moved to Ohio State, wrote another grant to study adult progression for a 5-year period. So we recruited over 300 subjects and followed them for 5 years, looking at their change in prescription. And then sort of since then, really, a lot of what I've been doing has been driven by industry partnerships. So I was involved a little bit with the approval of CRT in the, whenever it was, 2002, but that was just for the temporary reduction of myopia. Myopia control came to overnight ortho K and CRT a little bit later. But a lot of the work I've been proud to be involved with recently has been related to various endeavors with industry. So I work with atropine companies, spectacle companies, ortho K companies, and soft contact lens companies. So that's how I've sort of evolved over the years.
Yeah, and certainly myopia as a topic of research and trying to understand it better is something that was necessary, and it's something that's happened. I think part of it probably is just you being aware that this is something that needs investigation and more study. So speaking of that, I mean, I think back to being a student 25 years ago and what we were taught and my beliefs about myopia. And where I stand now, 25 years later, I have a very different perspective on all of it. So, can you talk a little bit about the evolution of how we understand myopia, who gets it, inheritance versus behavior, et cetera, and how your personal view of myopia has changed over your career?
Well, undoubtedly, myopia is a combination of genetic and environmental influences. And, there's been some mudslinging over the years between different camps, none of which is particularly productive. With modern genetic techniques, we are really unable to account for perhaps more than about 10% or at the most 20% of sort of school myopia, the common myopia.
Sure.
We can obviously pin down a lot more syndromic myopia that is rarer and often more severe. But we've always had this thing about, it's near work, it's accommodation, it's accommodative lag. I think where my current understanding is that it's much more about outdoor activity when it comes to myopia development and onset. But of course, once you've got it, outdoor activity may or may not have a great deal of influence. But taking a broader look, I think the interest that I have and other people have in myopia is down to three things. It's obviously increasing in prevalence around the world. We better understand its impact on visual impairment. So we've done some recent work that suggests that really, regardless of your criteria for visual impairment, you can blame about a third of visual impairment on myopia, whether it's myopic maculopathy, increased risk of glaucoma, or increased risk of retinal detachment. And then finally, of course, the thing that has a lot of people excited is the ability to slow down myopia or to control it. And that's really, I think, what's driving a lot of the interest right now, in the same way that, say, 20 years ago, dry eye wasn't much of an interesting topic, but
now it's huge.
Right. Yeah. Now with devices and drugs that we have available to us, we can do something about it. So,
so are you saying that we should be investing in outdoor reading stations or what?
Well, we don't know exactly what the secret sauce is when it comes to outdoor activity. Is it the amount of light? Is it the color of light? Is it something related to dopamine or vitamin D? Is it just the dioptrics of it, changes in pupil size, or just, when you're outside, the dioptric field, if you like, is very flat.
Correct.
Everything's far away. Whereas when you're inside, I mean, I've got you on my screen at about 50 centimeters, but I've got TV over there at about 6 feet. And, I'm looking also out of the window. So I've got a variety of dioptric distances. And one school of thought is that it's that mix that isn't good for us. So lots of work to be done by other people.
Yeah, I think, I totally agree. And I think that as much as we're understanding it better, we could probably talk for hours about the theories still that need to be fleshed out and figured out. So that, again, going forward, it goes beyond just what we're doing now, but we come up with even more appropriate or more impactful ways of managing it. So, um, on the topic of myopia, we've got a meeting which we just had a couple of months ago, and that would be the Global Myopia Symposium, or GMS. That's brought to you by Contact Lens Spectrum. This year, the conference was held again in September, but it's still available on demand for those with interest in growing their knowledge and skills in the area of myopia management. So you're on the planning committee for that, correct?
I'm afraid so. It's my first year, so I can't take any credit for what went on last year.
Gotcha. How'd you get roped into that?
I'm not sure, really. Obviously, sort of committed some heinous crimes in a past life, or maybe even the present. But yeah, I think somebody was rotating off, and they thought,
I think it was an appropriate selection. And honestly,
well, that's nice to say. So, I get to work with Jason Nichols, who's
I was going to say it's a great group to be part of, honestly. So
yeah, and with Kate Gifford, Oliver Wu, Jeff Wallin, Shalu Pal, we got a good blend with myself of practice and research. So we're excited to be putting together another great show. Disappointed in some respect it's going to be online, but nonetheless, we hopefully will bring some good content to people.
So give us, if you don't mind, a little bit of a synopsis of what the meeting is about. What kind of features, and we have lectures, we have posters, we have networking opportunities, we have industry. What kind of things would we find for somebody who's never attended and doesn't even really know much about it? What could they expect if they were to attend GMS?
Yeah, I think the goal is always to bring something for everybody, regardless of what your entering level of knowledge is. So if you're dipping your toe in the water for the first time, you can get an overview. If you want some content on tough cases or challenges, you can get that. There's breakout sessions on instrumentation. And a lot of the main sessions tend to be very interactive and with multi-speakers. So you won't find yourself listening to me droning on for 2 hours. You'll have a lot more interaction amongst sort of 3 or 4 or 6 panel members, each presenting different content or answering case challenges or philosophical questions. So that's what we try and do. And of course, the field is moving so rapidly that what will be presented next year will be different from this year, but the goal is to make it up to date and also to bring in international perspectives.
Yeah, I think, like you say, it's changing a lot. I think a lot of what's changing is the clinical side of it for the average practitioner. The research has been going on for some time and continues to, and the understanding of it continues to evolve, even more so, probably because, again, we've got more support for it now as we see it expanding into more and more clinical practices, the widespread acceptance of managing it. So I think that having these panels where you've got people with different perspectives, it is a little different than some areas where there's still, where it's pretty widely known what to expect and how to manage it. But with myopia, I think there's still a bit of debate, and I think having that debate in front of our attendees is great.
Yeah, I mean, the thing that surprised me most about the meeting this year is that the involvement of the Asian Optometric Congress and the diversity that brought. We think of, in our provincial way, we think of Asia as one big blob. But we had people from Taiwan, from Hong Kong, from Malaysia, from mainland China. We had perspectives from Australia. So it was really rich, the diversity of perspectives we got.
Yeah. And I was going to digress onto a side note, talking about a sister meeting of GMS, which is the Global Specialty Lens Symposium, which is also brought to us by Contact Lens Spectrum, held in January in Las Vegas. So if you're interested, everybody, it's not too late to sign up. Will be a live in-person meeting this year with a virtual component as well. We talked last show, I had A. Vanderwarp on, and we talked about how GSLS is such an international conference, a global conference, but in a way, I feel like in many ways, Myopia, the GMS, could almost be more international. I think Myopia and the ideas behind it and the management of it and the understanding of it is really being led by Asia, where specialty contact lenses over in Asia are other than Ortho K are much more in an infancy stage. So GMS really could and should be more international even than GSLS. So, can you talk a little bit about how the differences in understanding myopia and how it's being studied are from, let's say, Asia to Australia to the US, Europe? I mean, the global differences in how people look at myopia.
Yeah, I mean, I think there are, first of all, some philosophical differences on how to manage it or control it. And the great divide there tends to be between ophthalmology and optometry, where ophthalmology tends to be very much atropine and sort of some, how shall I say, suspicion and aversion to putting kids into contact lenses, whereas optometry tends to be much more broad-based and sort of embrace all the pillars of management, be it spectacles, atropine, soft contact lenses, or Ortho K. The other thing that you see around the world is there's variations in scope of practice. So obviously, a lot of optometrists around the world with a more limited scope of practice can't prescribe atropine. And also some of them can't use cycloplegic drugs. So you'll see an axial length have a more important role because you can measure it very precisely with the modern optical biometers without needing cycloplegia. The other thing that really impacts us in the US is the regulatory issue. So people in Europe and say Hong Kong have access to much more in the way of spectacle lens technologies, the new lenses from Hoya and Essilor, and likewise Sightglass Vision and Cooper Vision are launching their spectacle lens in parts of the world in the coming months. So we end up being behind the curve in the US because of the FDA. Now, we like the FDA in terms of some of the things it does, but it can be a little frustrating that people in Canada have access to the new spectacle technology and the new Johnson & Johnson soft lens, whereas we probably have several years to wait south of the border.
Yeah, unfortunately, yeah. So that's great lead into kind of what I wanted to ask you next, and that is thinking about our therapies for managing myopia. We touched on the optical therapies, which would be Ortho K, soft multifocals, spectacle lenses, depending on what part of the world you're in. And then the pharmacologic, the atropine, whatnot. Do you think that we are destined to work with these modes and just try to improve them? Or do you think there's some type of breakthrough that we don't have yet, going back to the idea again of dopamine, of ultraviolet, or different wavelengths of light? Do you foresee that, down the road, 10, 20 years, we have something to manage myopia that we don't even necessarily are barely scratching the surface of, if you will?
Yeah, I mean, starting off with what you mentioned about sort of light, there's a paper just been published suggesting that red light therapy is effective at slowing progression. Now, I haven't fully digested the paper yet. It's only just come out. But that gives you some idea of what people are trying. There's various intellectual property about sort of projecting images or light onto the peripheral retina. There's some IP out there for ultraviolet light. So that's one area I think we're going to see a lot of activity in. Soft contact lenses, my site was the first sort of flag in the ground, so to speak, and other companies will try and match it or better it. So we'll see what happens there. Overnight orthokeratology, I hear all this chatter about custom fit in, and I think particularly for the low end of the myopic spectrum, you can do better if you do something rather than just fit in a standard ortho-K fit. But I've yet to see any data that convinces me that how to do this and what the effects are. I would say 3 years ago, we couldn't have foreseen the dramatic improvements in control that we're getting with these sophisticated and creative spectacle lens designs like DIMS and Stellest, which is the Hoya and Essilor products. So who knows what will come along there. And then with atropine, there are 3 companies pursuing approval of low concentration atropine in the US. But undoubtedly, there are other companies who are looking at more selective drugs, because atropine is kind of a sledgehammer in so much that it's a non-selective antimuscarinic that blows your accommodation and pupil if you put the full dose in. But if you had a selective antimuscarinic that had its action at the retina while leaving the front of the eye unscathed, that might be very attractive. And people, pirenzepine was one example of that never came to market, but undoubtedly there'll be other drugs developed.
Yeah, with a higher concentration or higher efficacy on the myopia management part and less on the other side effects that we don't want, like the dilation and that would be great to be able to have a more potent pharmacological effect on the aspect we want, but not on the things we don't want.
Yeah, I mean, we're still trying to learn what's the optimal concentration of atropine, and undoubtedly it sort of might vary on the preparation and which pharmacy you get it from. But there's probably a sweet spot in the middle where you can get maximum effectiveness in slowing myopia progression without the deleterious effects of pupil dilation and loss of accommodation. So we got a lot to learn there as well.
Yeah. What's interesting is I think, and we've spent this whole time talking about myopia management, which it is, but the core of this really is we're managing the ocular health. We're managing the axial length growth of our patient. And I think that from an optometric standpoint and ophthalmology too, moving this to, instead of a refractive condition that we're trying to manage, which seems, again, like different than a disease process, which really it is, because you already mentioned how 1/3 of vision loss in the world is due to myopia. I think if we start taking the mindset that this is a disease we're managing and these therapies are just our interventions, and we can, with axial length measurements, we can set targets. With refractive error, we can set targets. We can prescribe and we can manage, and we can achieve our target outcomes, or we can alter our therapy if we're not. It really is much like managing glaucoma or managing dry eye, where we can be objective and we can set goals, and it can be a medical optometry, medical ophthalmology type of management, which I think a lot of people find exciting, that this is another area of a medical condition worth managing. So it's definitely an exciting time. To see the evolution of the thought process of most practitioners in such a short time frame, going from, well, I don't know about this, to, yes, I want to embrace this and I want to incorporate this. It's truly exciting, and it's a whole new realm for us, again, in terms of having a subspecialty or a area of specialty in eye care to grow and to benefit our patients. As we wrap up, give me one more bit of insight into myopia or myopia management that we haven't covered, that I can look forward to hearing about in meetings down the road when I attend GMS in a couple of years. What might we hear more about than we do now?
I think, we're still getting a handle on slowing myopia progression, but one of the things that I think will become more important, particularly for those of us on the front line and in clinical practice, is promoting myopia prevention. So we know about the link between outdoor activity and risk of myopia. So we know we have in our hands, even if we don't want to prescribe contact lenses or pharmaceuticals for myopia control, we can encourage outdoor activity and behavioral changes in our young pre-myopes, particularly the ones at high risk based on their refractive error and their parental history. We can encourage them to be more outdoors. But I think we'll also see some results for maybe some pharmaceuticals like atropine being prescribed before the onset myopia with a view to delaying its onset. So I think that's something that in the next 5 years, we're going to see a lot of activity on. And of course, we're going to see a lot of activity on combination therapies, be it spectacles and pharmacology or contact lenses and pharmacology. So that's just there'll be a whole lot of information on that.
Yeah, I think that's spot on. I think myopia prevention is probably where we were with myopia management 5 or 10 years ago. And that probably will be something that a lot of people who are embracing myopia management haven't really thought a lot about getting involved at an earlier stage. But I do agree, there's a lot of potential for that. So that's something to look forward to, adding myopia prevention to our management of that condition. So thank you.
It'll keep me busy and interested for another 5 years at least.
Correct. Plenty to do. Well, again, thank you so much, Mark, for being here as we pull this in. I just want to mention our upcoming episodes, our guests. Our next episode in January, we're going to talk with Maria Walker. Maria, of course, has a special interest in research and fitting of scleral lenses, specialty lenses. We'll talk to Maria about the GSLS conference. So that'll be the week before GSLS as a primer for that. And then, of course, in February, we come back to myopia again, and we're going to have someone you know really well, another member of your committee, Kay Gifford, will be our guest in February. We'll talk again about myopia at that time as we prepare for future myopia meetings as well. So again, thanks much. Enjoy your coffee and your skiing. And I look forward to
some more work to do before I can hit the slope. So I got some needy clients that, but things that are time sensitive. So yeah, I'll try and get a couple of hours in the soft.
Try to get in before the day's out. So hopefully see you in Las Vegas next month.
Yep. Look forward to it.
Wonderful. Thanks again, Mark. And thank you all for being here for this episode of CLS Live. Have a wonderful day.